So Saiti, we can go on live.
Yes, sir.
Please.
Sir, only 1 second before you start. Patel sir, what do you feel? Should we send the representative last question or should we keep quiet?
No, that is up to you.
No, like from your past
somebody
experience.
should be there, then you can very well send.
Okay, fine. Thank you. That's all.
Yes.
Okay. Because of your experience, I asked. Okay, sir. Thank you.
Yes.
Saiti, please share the slide. Yeah. So very good evening, doctors. We are on live and we are starting the session. So I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for the today's APOGS ABHYAS webinar series. I welcome all the chairpersons, chief guests, speakers for the day. But I request to share the convener for the today's program, Dr. Umashankarsa. Umashankarsa has done his MBBS, MS and OBGYN, and that sir has done his diploma in laparoscopic surgery, diploma in IVF from Kiel University, Germany. And sir is also a practicing endoscopic surgeon. Sir is currently the clinical lead and infertility specialist at Halia Hospital, Guntur, Andhra Pradesh. Sir is currently holding the joint secretary in GOGS, APOGS secretary, executive member in APISA, and organizing secretary with 5th APCOG. Sir has received various awards. In specific, Sir has won the Jagadishwari Mishra National Award for poster presentation in Cochin in 2006 and in Mumbai in 2013. And Sir has won India's Greatest Leader Award in the year 2016-17, Inspiring Gynecologist Award and IVF Award India Award 2019. With this short introduction, I welcome you, sir. And sir, over to you, sir.
Good evening, everyone. I welcome all the society presidents, secretaries to ABHYAS series, and I welcome our beloved MC Patel sir, who has been an inspiration for me throughout my career. And also seeing him, sir, conducting happy learning classes, we thought we must, being youngsters, we at least try to match sir in some bit. And we are very grateful to you, sir. You have always been our teacher. ABHYAS series is started with a unique concept to involve many societies from north, south, east, and west, so that all the societies will share their experiences with each other. And together we stand as a united, strong, foxy body by sharing our experiences. And another important is to include young new speakers to all the organizations so that they can become national faculty at one time. With this, I'll like to introduce our chief guest today, our beloved MC Patel sir. Sir is a consultant obstetrician, gynecologist, and medico-legal counselor, vice president of FOXY 2018, organizing secretary AICOG 2017, chairperson's ethics and medico-legal committee FOXY 2011 and 13, honorary joint secretary, state organization of gynecologists and obstetricians of Gujarat, honorary secretary elect, state organization of gynecologists and obstetricians of Gujarat 22 to 24, organizing chairperson MMCon 2018, honorary member National Inspection and Monitoring Committee PNDT Act Government of India 2015, honorary member State Supervisor Board PNDT Committee Gujarat State 2005 to 2009, President Ahmedabad OBG Society 2010 to 2011, honorary member National Managing Body Indian Red Cross, National President National Medicos Organization 2016 to 18, President IMA Ahmedabad, honorary surgeon Indian Red Cross Eye Bank. This is very important, sir, which I really appreciate you, sir, for collecting more than 1,000 eye pairs. It's really great, sir, that you have donated a site to nearly 2,000 people. Organizing chairperson Vivekananda NMO NOMCON, President Lion Clubs Galtora Ahmedabad, convener Ahmedabad Jilla BJP Dr. Sel, sir. As a BJP person, I also congratulate you, sir. I am Araki Swayam Sevak of Guntur Jilla, sir.
Thank you.
So with this, I would like you to give a few words.
So thank you, Dr. Umashankar, for generous introduction and kind words. At the outset, I would like to thank APOGS ABHYAS web series organizers for inviting me as a chief guest to bless you all and to share my views about the subject. It is always nice to go for ABHYAS. ABHYAS means continuous learning process. And we are always student. Many times I say, I consider myself as a student. And when we consider ourselves as a student and we go on learning and updating our knowledge, ultimately, it is not only useful to us only, but to society as a whole and to our patients also. Because being an obstetrician, our ultimate goal is to check maternal mortality and infant mortality and not to end up into any morbidity or any mortality of any of our patients. Because the government has given a target by 2030 that maternal mortality in India, it should be 76 and neonatal mortality rate, it should be 12. So there are few states in southern India, they have already having this maternal mortality rate nearby 30 or 32. But at the same time, there are few states, particularly in northern and eastern India, they are having maternal mortality rate almost 200 or even more than that. Say, for example, Assam is having 225. So if we want to achieve that goal of 76 of FMR by 2030, then it should be a joint venture on part of government, NGOs, federation like FOXI, IMA, then a medical fraternity, and particularly our obstetrician friends who are working in rural area, because they are the main person to take care of our rural population as far as obstetric part is concerned. So I congratulate this organizer of this ABHYAS web series to design these very important issues for discussion. And I also congratulate all the societies who have joined this web series. That is Guntur, Dr. Venkateswar and Umashankar, President and Secretary respectively, Kadapa, Dr. Padmalata and Pramoda, Rajamundri, Dr. Padmaja and Divya, and Vijay, Dr. Sailja and Padmaja. So, and you have very nicely selected the topics for discussion. Anemia, we know it is a very common condition in our day-to-day patient when we encounter any patient. And in one of the survey, it was said, if we go with strict definition of anemia by hemoglobin, then almost 50%, or in many times more than 50% patients are anemic. And we know when we are dealing with an anemic patient, from conception to full-term delivery, we are having so many complications related to anemia in pregnancy. Say, for example, abortion or prematurity or preterm delivery and PPH also. And we know if we are facing case of PPH and patient is already anemic, then how it becomes difficult to manage this type of situation. So you have very nicely selected the topic of anemia, and you have also rightly selected learned speaker, Dr. Sama Sultana, and she is going to justify her role as far as discussion of this topic is concerned. You have also very nicely selected the subject of IUI. It is also very common practice. So many of our Foxian friends, they do not practice level 2 infertility practice, but up to IUI, so many of our friends are facing practice, and it is a very nice topic for discussion. And again, you have rightly selected learned speaker, Dr. Rekha Rajendra Kumar, and she is also going to justify her role as a speaker. And one more topic you have nicely selected, UTI in pregnancy. It is also very common symptom and entity during pregnancy, and it becomes a difficult one many a times for patient and gynecology if it is not treated in time. So, and for that, Dr. Sirisha is going to deliver the talk, and she is also going to justify the topic. And very important topic, antibiotics in pregnancy. It is also very important topic, because if at all antibiotic, which which should be avoided during pregnancy and it is prescribed and something goes wrong, then it may invite litigation in court of law, and it becomes very difficult to face litigation in court of law. So it is also very important topic, and Dr. Lakshmi Priya is going to discuss that topic, and she is also going to justify the topic. And all the learned chairperson who have kindly consented to be a chairperson for respective session, Dr. Geeta, Dr. Pramoda, Dr. Sridevi, and Dr. Divya, they are also going to justify their role. So congratulating again APOGS and Society for designing this webinar, and Dr. Umashankar in particular. And I see so many of the faces on this webinar on screen who had been faculty in my series of Happy Learning Masterclass. So thank you for giving chance to meet all of them again and again on the screen at least. So thank you, Umashankar.
Thank you, sir.
All
Blessings,
the best
sir.
for your
Thank you.
Foxy venture, Umashankar and Rekha, for your post of chairperson, respectively for medical education and clinical research. So congratulations again to organizers for designing this program. Thank you very much.
Yes, sir. Thank you. So we have today with us Dr. Priyanka Rai, who is on journey. He will join us slowly. He is the guest of honor, and Dr. Ganga Madam. She is busy with the case. Dr. Stalin, can you have the lamp lightning, please?
Thank you, Patel sir.
Yes, sir.
So,
Thank you, madam. So, Stalin.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
So we have Dr. Priyanka Roy. He will be joining us shortly. Dr. Ganga Madam, she is held up in a place. Dr. Venkateshwara sir is in Australia. He had to go immediately. So he is adjusting the time, sir. With this, we will start our first session, Anemia and Pregnancy. For that, we have Dr. Geeta Vandana. Madam, are you there, madam? Dr. Geeta, madam? Geeta Vandana, madam?
Yes, sir. Yes, sir. I'm
Yes, madam. Yeah, worked as an assistant professor, OBGYN Andhra Medical College for 17 years. Worked as associate professor in OBGS in Andhra Medical College for 4 years. Consultant gynecologist at Medicover Hospitals. She has expertise in high-risk obstetric procedures, infertility management, laparoscopic surgeries, surgeries like pregnancy accreta, scar ectopics, and ruptured uterus. Madam, please take over the session from now. Madam.
Thank you, sir. Thank you for the introduction. Anemia in pregnancy is a global health problem today. WHO estimates that nearly 40% of pregnancies are complicated by anemia. And in developing countries like our country, it is still a major contributing factor for maternal mortality and morbidity. Today we have Dr. Shama with us. Dr. Shama with us to enlighten us regarding anemia in pregnancy. Dr. Shama is a young, enthusiastic and cheerful obstetrician and gynecologist, as well as infertility consultant. She is a chairman and co-founder of Hope Win Hospital, and she is also working as gynae consultant at Star Hospital, Guntur. She did her PG diploma in assisted reproductive techniques from Kiel University, Germany, and she training in basic ultrasound and endoscopy from Fox. She has diploma in aesthetic gynecology. Also, she has colposcopy expert training from Delhi Gynec Forum. She has been a speaker in Community Connect program and Preventable Women's Healthcare held in 2021. She is a public awareness in charge in Sexual Medicine Committee, FOXY, and editor-in-chief of Parag Patil's Awareness E-Digest. She has served as a faculty in adolescent sexual health are organized by POGS June 21. She is also founder of Yuvanari Healthcare Guntur program for adolescent and young ladies. With this, I request Dr. Shama to continue.
Yes, thank you, ma'am, for the kind introduction. And good evening, everybody. And thank you for giving me this opportunity. So today's my topic is anemia and pregnancy. Sharing once again, sir. I'm sorry for the delay. So anemia and pregnancy. WHO defines anemia in pregnant women as a hemoglobin below 11 gram per dl and a hematocrit of less than 33%. So Center for Disease Control defines anemia as a hemoglobin concentration less than 11 gram% in first and third and less than 10.5 gram% in second trimester. So epidemiology, as ma'am said, there is in developing countries and India, it is 40 to 90% and compared to 10 to 20% in developed countries. And by classification, it is mild, it is 9 to 10.9 gram per dl and moderate 7.8 to 9, severe less than 7 and very severe is less than 4. So classification of anemia, it is physiological and pathological. Physiological, it is as pregnancy causes a state of plethora in which the RBC mass increases by 30%, whereas plasma volume increases by 40 to 50%, resulting in erythrocyte dilution by 5 to 15% and decrease in hemoglobin concentration by approximately 2 gram per dl. So the picture on the peripheral smear remains normocytic and normochromic, and the decrease in the blood viscosity facilitates better blood flow through placenta, and also the increased blood volume also offers a protect. Whereas the pathological anemia, that is deficiency anemia, that is iron deficiency 60% it creates, and macrocytic anemia 10%, folic acid and vitamin B12 deficiency, and dimorphic anemia in which both are seen, and protein deficiency in extreme malnutrition. Whereas in hemorrhagic anemia like acute blood loss, chronic like hook form infections and bleeding piles, hemoglobinopathies, thalassemia, sickle cell anemia, and aplastic anemia, anemia of infection, and chronic diseases like renal, hepatic, diabetes, thyroid, or neoplasms. So here we see as a erythroblast is normally converting into mature erythrocytes, whereas in abnormally they will grow up to macrocytes. So what are the effects of anemia in mother? We see are in antepartum complications, we see abortions, intercurrent infections, and preeclampsia, APH, and preterm labor and cardiac failure. Whereas in intrapartum, there could be uterine inertia, dysfunctional labor patterns, and increased risk of instrumental deliveries, fetal distress, cardiac failure, and shock. Whereas in postpartum, puerperal sepsis, subinvolution of uterus, failing of lactation, puerperal venous thrombosis, pulmonary embolism, cardiac failure, and delayed wound healing will be seen. Then what are the effects on the fetus? There could be intrauterine growth retardation, prematurity, increased risk of iron deficiency anemia in early infancy, congenital malformations, stillbirth, intrauterine deaths could be seen due to severe maternal hypoxemia, then increased neonatal death or perinatal mortality. What are the symptoms we'll be seeing in means pregnant women? They are lack of concentration, infection, palpitations, dizziness, lightheadedness, irritability, pica. Pica means a craving to eat something which is not eatable, like mud or hair or something. So it is the one type of craving which is seen in the severe cases of anemia, and fatigue, weakness, and dyspnea on its exertion. So what are the signs? They are pallor of mucous membrane or nail bed, glossitis and stomatitis, plateonychia or polynychia, tachycardia, tachypnea, ejection, systolic murmur, ankle edema, increased jugular venous pressure, postural hypotension. So how we can know? First of all, as the patient comes to us, we will have a detailed history, age, race, parity, dietary habits, and she was passing any worms in stool or history of any bleeding per rectum, hematuria, hyperemesis, malabsorption, or chronic diseases like TB, malaria, bleeding disorders, or etc., and history of drug intake or repetitive blood transfusions, if any. And we will examine for pallor of mucous membrane and nail bed, lower conjunctiva, and glossitis, cheilitis, splenomegaly in case of hemolytic anemias, jaundice in hemolytic anemias, and purpura in some bleeding disorders, leg ulcers as in case of sickle cell anemia, neurological deficit, megaloblastic anemia, and anasarca and signs of cardiac failure also in severe cases we could see. So how we could approach is universal screening for iron deficiency anemia with hemoglobin is recommended in all pregnant patients at first antenatal visit with a presumptive diagnosis of iron deficiency anemia. A trial of oral iron for 2 weeks is recommended in patients with mild to moderate anemia. Further investigations are warranted if patients do not respond to trial of iron, that is rise in HB in 2 weeks is seen. If it doesn't seem, we have to go for further investigations. An empirical trial of oral iron for 2 weeks is advised up to 30 to 32 weeks of gestation in patients with mild to moderate anemia. So investigations like severity of anemia, like HB and hematocriticality, and type of anemia, peripheral blood smear and red cell indices we can see, and bone marrow activity for reticulocyte count. Then red cell indices like RBC count, we will see it normal, it could be 4 to 4.5. Then majoritarily MCV, we consider average volume of red blood cell 80 to 96 it should be. Then in case of microcytic, that is MCV is less than 80 and macrocytic it is more than 100. In case of sideroblastic anemia, iron deficiency anemia, it is microcytic. So normocytic, that is 80 to 100, that is high reticular count. In case of sickle cell anemia, hereditary spherocytosis, autoimmune hemolytic anemia, means acute blood loss, we will see high reticulocyte count. In case of low reticulocyte count, it is aplastic anemia, renal failure, and myelofibrosis. In peripheral blood smear, if it is normal, it would be seen normocytic and normochromic. And in iron deficiency anemia, it is microcytic and hypochromic, and anisocytosis is seen in folliculocytosis with or without target cells. And we will see malarial parasites, and aplastic anemia shows low or no counts, and sickle cell, we can see a sickle-shaped RBC, and triad of oval macrocytes, oval jewel bodies, and hypersegmented neutrophils seen in megaloblastic anemia, and abnormal blast cells are seen in target cells in case of thalassemia. So iron indices which are abnormal, they are serum ferritin, serum iron, and iron binding capacity. All these parameters we would see in deficiencies. And other investigations like serum creatinine, blood urea, and in renal diseases, and liver function test in case of hepatic disease, urine examinations for RBC and CAST, and stool examination for occultable blood and ova, and bone marrow examination for refractory anemia, X-ray chest, and for pulmonary TB, and ultrasound whole abdomen. So we'll see about iron deficiency anemia. So in this, first of all, iron requirement, it is total iron demand in pregnancy is 900 mg. So in this, altogether 225 mg of iron is saved as a result of amenorrhea of 9 months. So average requirement is 4 to 6 mg per day, 2.5 mg per day in early, and to 5.5 mg per day from 20 to 32 weeks, and 6 to 8 mg per day from 32 weeks onwards. So what happens is the food iron, that is the supplemental iron which we take, it is absorbed into the intestine, and by hemotransporter it is going into the blood vessel, and from there it is absorbed into the bone marrow and further erythropoiesis. So the stages of iron deficiency, as you see in the normal case, storage of iron or transport of iron in RBC are intact, whereas in iron deficiency anemia, everything is decreased. So causes of iron deficiency anemia and pregnancy, there could be increased demand, that is 1000 mg for growing fetus, placenta, and blood loss during labor, and also decreased intake, that is due to many cases of hyperemesis gravidarum or any type of nausea, vomitings. In such cases also there will be a lot of faulty eating habits. They will be not be taking a healthy food which they have to take, and many of the times when I counsel the patients, many of the times they will be eating, in spite of a healthy food, they would be taking some other junk food which would be satisfying their craving but not healthy. So there will be a faulty eating habits, and due to the loss of appetite and vomitings, in majority of the cases there would be decreased intake. So disturbed metabolism, low erythropoiesis, and pre-pregnancy iron status or anemia, repeated pregnancies, and hookworm infestations and bleeding piles could be one of the cause. And how we can diagnose by total iron binding protein, and that would be raised, and RBC protoporphyrin, it is increased, and serum transferrin receptors are increased, serum iron and percentage saturation which is less than 16%, and serum ferritin will be low. So these are the various parameters and various diseases in which there will be a microcytic hypochromic anemia in case of iron deficiency anemia, chronic diseases, and thalassemia and sideroblastic anemia. So MCV is almost decreased in iron deficiency anemia, whereas in sideroblastic it is normal. And prophylaxis and treatment in few cases like Menser index is an index used to differentiate iron deficiency anemia from thalassemias, and formalize MCV by RBC count. Value for IDA is greater than 13, value of thalassemia is less than 13. So as per Indian diet, there is no matter in which from India means iron is being taken, only 10% of it is absorbed. So typical vegetarian Indian diet contains large quantities of inhibitors actually. So Indians obtain non-heme iron from cereals, pulses, vegetables, and fruits. So Indian diet is plagued by low iron content and poor absorption. So impossible for Indian population to meet iron requirement by normal diet. It does not cross greater than 10 to 15 mg iron per day. So National Nutrition Monitoring Bureau survey shows that intake of dietary iron is grossly inadequate, and it is in most of these states in India meeting less than 50% of RDA. Therefore, iron supplementation during pregnancy is recommended universally, even in a non-anemic women. So few principles like plate should have a fruits, grains, vegetables, and protein, and it should be very suggestive. Gynec should suggest the complete diet which you could take and which can supplement iron in an appropriate way. So iron-rich foods like meats, egg, and seafood, bread, cereals, fruits, beans, and other foods and vegetables should be suggested. So these are all the requirements. And impaired iron absorption, like in case of higher consumption of tea and coffee, and calcium found in dairy products such as milk. And also we will advise them not to take iron and calcium tablet at once, as it may impair the absorption of iron. And antacids, protein pump inhibitors, which affect the production of acid in your stomach, and some whole grain cereals contain phytic acid. So National Nutritional Anemia Prophylaxis Program, in this ferrous succinate and ferrous ascorbate, this ferrous sulfate and ferrous ascorbate, ferrous sulfate 100 mg and ferrous ascorbate 500 microgram in case of pregnancy, lactated mothers and adolescents, women of reproductive group to be given weekly, children, infant reduce their we can reduce the dose. And WHO recommendation for prophylaxis of anemia based on the prevalence of the anemia, 60 mg of elemental iron plus 400 microgram of folic acid per day, and recommended for 6 months where the prevalence is less than 40%. This dose is to be supplemented for another 3 months if prevalence is greater than 40%. So these are the few recommendations. First thing is we have to give awareness about the health and the importance of taking dietary supplements, iron rich food. And then what we have to explain, the daily iron supplementation it should give, and we have to prescribe it. And in first antenatal visit, it is recommended to see what are the HB levels and all. And first, when the pregnant lady comes and establishes mild to moderate severe, means mild to moderate anemia, we should do a trial of oral iron, and we can see if there is rise, it's okay. But if not, we should have a further investigation, and we should keep, if there is a mild to moderate, then we have to keep twice a day 100 mg elemental iron. And after achieving the normalization, we could continue once daily elemental iron for is recommended for at least 6 months during pregnancy, and should be continued postpartum for another 6 months. So pregnant women on oral iron supplements should be counseled about steps to reduce gastrointestinal side effects as well. And these includes consuming the tablet at least about 1 hour after the meal. 1 hour before the meal, along with absorption enhancers like vitamin C. It will be very better to reduce the gastrointestinal effects. So parenteral iron is recommended for women with anemia who do not respond to or intolerant to oral iron. Among the newer intravenous formulations, iron sucrose is approved for use during pregnancy, though it is better avoided during the first trimester. So parenteral iron is also recommended for pregnant women with severe anemia who require rapid restoration of iron stores in second and early third trimester of pregnancy. And packed red blood cell transfusion should be reserved for those with severe anemia at any stage of period of gestation. So deworming using albendazole is routinely recommended after the first trimester to avoid the soil transmitted helminthic infestations. So we will see what all we can do stepwise. In the first estimation of HB, we have to do at 14 to 16 weeks. That is HB estimation and deworming we can see for this. And if HB is less than 7 gram per DL, blood transfusion and further management we can do. If HB is 7 to 10.9 gram per DL, then therapeutic dose, that is ferrous sulfate 100 mg and ferrous ascorbate 0.5 mg. BD means twice daily we can take along with the B12 supplements and vitamin C. Then a HB greater than 11 gram prophylactic dose we can continue. So second estimation at 20 to 24 weeks, that is after consumption of prophylactic or therapeutic dose. If less than 7 gram % blood transfusion, then 7 to 8.9 injectables like iron sucrose intravenous 4 doses of 100 mg over a period of 2 weeks with 2 to 4 days in interval. And HB 9 to 11 gram per DL, we can use supplements of iron like twice a day and along with B12 and vitamin C. Then HB greater than 11 gram per DL, we can continue with a single dose of tablet and along with vitamin C, B12. Then third estimation of HB at 1 month after the 4 doses and gestation age less than 30 weeks. So at this point of view, less than 7, same blood transfusion, and 7 to 8.9 we can do. If not received injectable iron sucrose previously in current pregnancy, then we can go for injectable like iron sucrose and 4 doses of 100 mg 2 weeks over a period of 2 weeks with 2 to 4 days interval. If they have been already received, then we can give 2 top-up doses of injection iron sucrose infusion intravenously 100 mg each. Then HB 9 to 11 gram per DL prophylactic dose we can give. So iron and these tablets, vitamin B12 and vitamin C, we can continue. And if in greater than means twice a day we can give, and once a day, and same thing HB greater than 11 we can give once a day. And estimation of blood hemoglobin at 30 to 34 weeks of gestation. If less than 9 blood transfusion, greater than 9 we can go for prophylactic dose. So iron therapy, oral therapy, and parenteral. In oral therapy, as I have already told, that 8 to 11 gram in early pregnancy, we can give oral supplements, and few contraindications which we see is intolerance to oral iron, advanced pregnancy, non-compliance, or failure to respond, inaccurate diagnosis, and faulty absorption, continuous blood loss, or coexistent infection. And we can see that indicators of response to therapy, feeling of well-being, and improved look of patient, better appetite, and reticulosis in 7 to 10 days, rise of HB 0.8 gram per DL per week have to be seen in as an indication of the response to therapy. So commonly available ferrous preparations are ferrous sulfate, which is the cheapest and mostly we use it, and all other preparations are these, and administration 2 hours before or 1 hour after meals, preferably with orange juice. So GIT intolerance is most commonly seen in as a side effect. So these are few supplements we give, iron preparations. So bioavailability of various iron is majoritarily highest as ferrous bisglycinate, that is 99.9%. So dietary factors affecting bioavailability of iron, that are few enhancers are heme iron present in meat, fish, poultry, and seafood, and ascorbic acid, which is very good, enhancer. And some germinated or fermented foods also are the enhancers. And inhibitors are like phytates present in cereal bran or cereal grains, and calcium particularly in milk, and tannins, phosphates in egg yolk, and oxalates in vegetables, excess of dietary fibers or inhibitors. And most of the time we have to avoid the intake of these inhibitors along with the iron tablet, or few means we can give few gap after eating this or before eating this tablet. So malabsorption of iron, like in cases of adult celiac disease, that gluten enteropathy, patient allergy to gluten in wheat, and diagnosis we can do by TTG antibody. If there are the IgA levels are improved, it could diagnose, and UGI endoscopy we can do, and D2 biopsy. Villus atrophy, we can go for gluten-free food in such cases, and IV iron for anemia. So parenteral therapies, few indications like contraindications of oral therapy, or patient not cooperative to take oral iron, or cases seen for the first time during the last trimester, or the 8 to 10 weeks with severe anemia if they have, and due to malabsorption or small bowel resection, or when hemorrhages is likely to continue, we should go for parenteral therapy. And where we can't take a parenteral therapy, there could be anaphylactic reaction to parenteral therapy, first trimester, and chronic liver disease and hemoglobinopathies, active infections, and oral iron is stopped at least 24 hours before to avoid toxic reactions. So few other side effects could be there: fever, arthralgia, and skin rashes, and lymphadenopathy, local pain, and skin staining will be there, and anaphylactic reactions would be there. And the rise in HB levels after means parenteral therapy is 0.7 to 1 gram per week, which is same as seen with oral as well. And the main advantage of parenteral therapy is certainly of its administration route. And how we are calculating, that is 250 mg HB deficit plus another 50% of replenishment of stores we can do, or 2.4 pre-pregnancy weight and into HB deficit plus 1000 mg of storage we can do. So parenteral iron preparations, intramuscular therapy we can do, iron dextran complex of ferric hydroxide plus dextran, and the dosage 100 mg in OD or alternate days till the total dose is over. So some drawbacks: painful injections, skin discoloration will be there. Then intravenous preparations like iron dextran, iron sucrose, sodium ferric gluconate. Intravenous preparations, like as I told you, the advantage of iron dextran is the possibility of giving larger doses of iron up to 1000 mg in one sitting. So a test dose should be given before every infusion. 25 mg of iron dextran is added to 50 ml of NS and run over 10 to 15 minutes. A patient should be monitored for another 15 to 20 minutes. If there are no signs of adverse reactions, the rest of the dose diluted in 500 ml bag of saline and should be administered over 2 to 6 hours. The rate of infusion should not exceed 5 mg per hour. So adverse reactions, increased anaphylaxis, increased with TDI, and onset is 24 to 48 hours after administration. Effects subside within 3 to 4 days. Dose related are arthralgia, backache, chills, dizziness, moderate to high fever, headache, malaise, myalgia could be seen. Non-dose related like hypersensitivity reactions characterized by anaphylactic shock, CV collapse, or cardiac arrest would be seen. So we have to immediately stop the infusion, give antihistaminics and corticosteroids or adrenaline. So iron sucrose, venofer, that is commonly used best in chronic kidney diseases, and the iron hydroxide sucrose complex in water. Then these are each ml contain 20 mg of iron, total of 5 ml, and after IV administration, it dissociates into iron and sucrose. This TF is 6 hours. And this iron sucrose is best thing is no test dose is required, may be administered IV push undiluted at 1 ml per minute, maximum dose being 100 mg, that is over 5 minutes, as 5 ml contains 100 mg iron. So another way is to dilute 200 mg to be diluted with the 200 ml of NS, infuse at least 20 minutes. Marked increase in reticulocyte count expected is 7 to 14 days. So 3 times weekly we can give, and 200 mg maximum dose per sitting, and rate of administration should be more than 20 mg per minute. So mostly adverse reactions could be seen less than, means some fuel greater than 5% of patients, that is hypotension, cramps and leg cramps, and nausea, headache, vomiting, diarrhea could be seen. So precautions, they should not be iron overload or infusion too rapidly can cause hypotension, headache, nausea, vomiting, dizziness, joint aches, paresthesia, and abdominal and muscle pains, edema, and CV collapse could be seen. So IV fluids can be given to such patients, and hydrocortisone antihistaminics, or slow down the rate of infusion. So sodium ferric gluconate, no test dose is required, available as 12.5 mg per ml, administer small installments of 125 mg iron or less diluted 100 ml of NS, infused over 60 minutes. So in this also, hypotension and flushing associated with rapid administration, not associated with hypersensitive reactions, and it resolves within 1 to 2 hours. So advantages of iron sucrose over other is, it as I told you, no test dose recommended, it has minimal side effects, it is usually not associated with anaphylactic reaction and preferred in hemodialysis, and it is capable of causing tissue peroxidation except iron sucrose, less oxidative injury and less risk of tissue parenchymal injury by free iron, higher availability of erythropoiesis than iron dextran, safe in dextran sensitive patients. So newest fast acting IV molecules are ferric carboxymaltose and furomoxetol, ferric isomaltoside. So indications, few times we give erythropoietin as well. Rapid correction of anemia is less than 2 weeks, and chronic kidney disease also is one of the indication, and anemia not responding to parenteral therapy alone, and treatment of moderate to severe iron deficiency as an alternative to blood transfusion. So dosage regimen, injection erythropoietin can be given along with parenteral iron in dose of 50 to 150 unit per kg. Given subcutaneous twice, first dose after a subcutaneous sensitivity test, adrenaline and hydrocortisone injection, and produces 3 gram %. So indications of blood transfusions are these. Whole blood can be given. So advantages, increase oxygen carrying capacity of the blood and stimulates erythropoiesis, and hemoglobin from hemolyzed red cells may be utilized for the formation of new red blood cells. Improvement is expected after the 3 days. So side effects, as you already know, risk of transmission of HIV and other, and transfusion reaction could be there, pulmonary edema could be there. So safe mother and healthy child. So management during the labor, first stage, the patient should be bed or propped up, oxygen inhalation, intermittent chest auscultation, strict aseptic conditions. And second stage, also stage in which we have to deliver the baby oxytocin concentrated form, restrict fluid, and prophylactic low forceps or vacuum delivery to cut short the second stage. And in third stage, active management of third stage, blood loss of with fresh packed cell transfusion or diuretics prior to transfusion, close monitoring of vitals, look for any genital trauma. In management of puerperium, prophylactic antibiotics, iron therapy for at least 3 months, and contraception. So, as we see in many of the other diseases like hemoglobinopathies, thalassemia, and appropriate treatments are available. So antenatal management, well, hydration should be there, effective analgesia, prophylactic antibiotics should be taken, blood transfusion, BT transfusions reduces pain, prevents crisis, and low doses of aspirin is recommended as a sickle cell disease is considered a mild risk factor for thrombotic episodes. So we can do HB estimations, peripheral smear, decreased MCV, MCHC, HbA2 levels we have to check, and HB electrophoresis have to be done. Then in case of prevention of iron deficiency anemia, where there is low intake and where there is increased risk of iron deficiency, we have to know and we have to advise them as well. So thank you so much for giving me this opportunity, ma'am. So thank you.
Thank you, Shama, for your excellent elaborative presentation. I have a doubt. Do we need to screen for iron deficiency without anemia?
Yes, ma'am. Means first, in the first visit, we need to check for it.
For all patients?
Yes, for all patients, ma'am.
Without anemia, iron deficiency screening for iron studies.
Iron studies, no, ma'am. If, as I told you, we have to, in anemia, first we have to do for oral therapy once for 2 weeks. If there is no increase in the HB level after 2 weeks also, we need to go for iron indices after 2 weeks.
Thank you.
Yes. Thank you, ma'am.
Thank you, Shama.
Thank you, sir.
Thank you, Dr. Geeta, for sharing this session, and Dr. Shama for giving valuable inputs. From this, we move on to our next session, that is tips and tricks of IUI. It will be dealt by Dr. Rekha Rajan from Bangalore, and is chaired by Dr. Pramoda. Can I have Dr. Pramoda's CV, please? Stalin. Yeah, Dr. Pramoda is the director of Matrushri IVF Clinic, Kadapa, and consultant Suraksha Super Specialty Hospital, Kadapa, visiting faculty at PIMS, Kadapa, and her affiliations are to POGS, IAG, IMA, ISA, AP chapter of ISA. She has MBBS from Kannur, MS from Kannur, and areas of interest are conducting live workshops, hysteroscopy, and ART. And the present position is Secretary of KOGS, that is Kadapa Obstetrics and Gynec Society, and Vice President of IMA, Kadapa. Welcome, madam, to this session of ABHYAS. Dr. Pramoda, from you, please take on the session. So, madam, you're muted.
Good afternoon, everyone. Is it audible, sir?
Yes, madam. Good afternoon, madam.
Yes, ma'am.
I am Dr. Pramoda from Kadapa. Today, I take privilege to welcome Dr. Rekha Rajendra Kumar, who is renowned gynecologist at Bangalore. Since beginning, she showed her excellence in academics. She stood as a topper in UG and PG university examinations. And apart from our specialty, she has other degrees like Diploma in Human Resources Development, Diploma in Health and Hospital Management, Diploma in Hospital Administration. She is practicing gynecology and infertility since 3 decades at Miracle IVF and Chandana Hospitals, Bangalore. She is holding various positions and like Vice President, Joint Secretary, BSOG, and South Zone Coordinator as a chairperson for Infertility Committee, She is an active member of various prominent societies like BSOG, FOGSI, KISAR, Indian Gynecological Endoscopy Society, PCO Society, Karnataka Cancer Society. Her quest in academics continued, resulting in many paper and presentations and many publications. And she is now continuing as speaker, chairperson, moderator, and panelist in many conferences and webinars till today. We welcome you, ma'am, and we request you to share your valuable experiences regarding IUI today. Thank you, ma'am.
Thank you, Pramoda madam. Thank you, Dr. Umashankar. It's my extreme privilege to be here talking, that too in the august presence of my guru, Dr. MC Patel sir. Thank you for the opportunity. Without much ado, I'll share my screen and continue my talk. Is my screen visible?
Yes, ma'am.
Okay, thank you. Yeah, the topic today I'm going to speak is about tips and tricks to improve IUI success. I thought it is a very good topic because the very beginning itself, Dr. MC Patel sir said that all gynecologists and all our FOGSI friends do IUI because in many ways it is useful, beneficial, patient-friendly, etc. But when we know that many of us are doing till the level of IUI, it is also very important to us, and it is our duty to see to it that success is also better as far as possible, though it is not so much comparable to IVF, but we have to think of improving the IUI success, the results to the patient, and put a broad smile on the patient face as far as possible, and that is our duty. And I'm here to explain some tips and tricks on that. Coming to the introduction of IUI, the rationale of the IUI treatment is to increase. All of us know that it is ultimately to increase the rate of conception. Whatever you do, we want pregnancy. We want the UPT to be positive. So to increase the rate of conception by increasing the number of gametes at the site of fertilization, that is at the fallopian tube. So it is a deposition of the maximum number of not only the sperm, it should be the washed sperm and the healthy sperm. I will tell you about the washing and how to get the healthy sperm in future slides, but we should see to it that we get the maximum number of wanted sperm there in the uterine cavity. At the same time, that should be done around the time of ovulation because we want ultimately the fertilization there. So as all of us know, IUI is a very simple technique. It can be mastered by one and all. It is safe procedure. We hardly see any complications in IUI. It is very non-invasive, relatively cheaper, that it can be obtained in any unit. Even small facilities, centers also can get the facilities, and it can be performed without expensive infrastructure. All of us know what is the infrastructure that we need for IUI. So with a reasonable success rate within 3 to 4 cycles. So it requires a minimum expertise and equipment to perform. According to ISHRE workshop in 2009, they said it is usually offered as the first line of treatment for couples with at least one patent fallopian tube, which should be not only a patent, it should be a healthy fallopian tube, which should be combined with the normal male parameters. So IUI with the ovarian stimulation is a safe and effective treatment for women with unexplained infertility. When a woman walks, the couple walk into our clinic, they usually walk into our clinic when they have tried enough at home, when nothing is possible, when they think that they need doctor's help, that is the time they walk into our clinic. So we should do something else, something extra, ultimately to get her pregnant. So it is a safe and effective treatment for women with unexplained infertility and who have an unfavorable prognosis for natural conception. That's what I meant, that they have tried enough. So what are the prerequisites in male and female? In male, we expect the sperm concentration, this is in unprocessed semen, of more than 10 million per ml of semen sample. When it is washed, that is a post-wash total motile fraction of more than 5 million at least, with a progressive motility of at least 50%. In female, what do I expect? The age should be less than 40, because all of us know that more than 40, ideally, she's not a candidate for IUI until and unless they very much insist on that. At least one healthy tube and a patent tube. The normal uterine cavity, we would have checked with HSG or sonosalpingography or ultrasound, whatever, and make sure that the uterus and the uterine bed both are normal, and definitely a good antral follicle count. So the critical factors to optimize the IUI success would be: one, my patient selection should be good. The ovarian stimulation is the second thing I'm going to concentrate on. Timing of insemination is extremely important. Sometimes we have to cancel this, situations, that is IUI, we would have given them the oral ovulagens, scanned, injections, gonadotrophins, etc. In spite of that, we may have to cancel the cycles. The cost effectiveness, all these are the factors we have to think when we want to optimize the IUI success. So everything falls into under these four important factors. These are the four pillars of IUI, I can say. One would be, or the first one would be the superovulation or ovulation induction. Most of the times we do not IUI in natural cycles. It's always some kind of mild stimulation with either oral or the injectables or injectable ovulogens we give, and that is what is called as a superovulation. The second thing would be the semen preparation. None of us do put the raw semen there. Then third is the proper IUI procedure once the semen is ready and her follicles are about to rupture or in around that time. Fourth is one should not forget to give the luteal support in IUI procedures. So coming to the first one, that is a superovulation or the ovulation induction. The woman is in the follicular phase. She has come to us on the day 2 of the cycle. Why I should give her superovulation? I should give her superovulation because I want more oocytes which are available for fertilization. More oocytes, more chance of fertilization. That is common sense. The correction of the subtle ovulatory dysfunction. When she is trying at home, probably she may not be ovulating at all. I'm going to monitor her by my transvaginal scan and make sure that how many eggs are coming. Are they growing according to my expectation? Is the endometrium going along with that? Is she about to rupture? When should I give the injection? That is a trigger injection, etc., etc. And that is timing of ovulation. Coming to the ovulogens, that are the drugs we give for the superovulation, is one, and the foremost one is the letrozole, which has been considered now. It is a consolidated fact that letrozole is much better than our dear and old friend, the long-standing clomiphene citrate. The gonadotrophin is better than letrozole, but multiple pregnancy rates one should consider, but they are much lesser. They are with letrozole because letrozole gives a monofollicular growth. The chances of multiple pregnancy is more with gonadotrophin. In IUI with gonadotrophins, time to pregnancy is much shorter. So many of the gynecologists or the infertility specialists start the woman directly on gonadotrophin from day 2 itself without any oral ovulogens. But if you are thinking of the cost, you have to cut down on gonadotrophins. You can give the letrozole from day 2, then on day 7 or 8 after ovulation monitoring, with ovulation monitoring, you can add the, or you can shift to gonadotrophins once the letrozole dose is over. So among the gonadotrophins, RFSH is better than HMG, though there are many studies like Cochrane study which says that all are same, all gonadotrophins are same. So factors which decide my gonadotrophin dose are: one is age of the woman. Older the age, I need more dose. AFC, lesser the AFC, I need more dose. Again, the dose that we decide on day 2 or day 3 is very, very critical and very, very important, and that is the deciding dose. There are many studies which say that if you change the dose afterwards, like day 7, day 8, there is not going to be much change in her response. The AMH, lower the AMH, definitely that's a poor ovarian reserve. I need more dose. BMI, more BMI, more dose, and don't forget to ask the previous records of the patient, because when they walk into your clinic, most of the times they would have gone to other places, window shopping, or some investigations might have been done, and some IUI treatment also might have been given. So you will get some gross idea how much of the dose you have to give, because how much of dose was given in the previous doctor's clinic and how did she respond to that. So these factors or these facts you may be able to know. So among the infertile couples, treatment with induction of superovulation and IUI is 3 times as likely to result in pregnancy, and that is why the minimum treatment what we would like to give starts with intrauterine insemination, that is IUI. Controlled ovarian hyperstimulation, IUI, increases the pregnancy rates in all indications except the severe cement defects, like it is indicated in almost all cases like unexplained infertility. But if the reasons or the indications are very, very strong and gross and very daring indications, like for IVF, those are the cases we are going to keep them for IVF and out of the IUI box. The ovulation induction cycle could achieve a higher pregnancy rate than the normal cycle in IUI, whether with CC, HMG, or any of the combinations, particularly for the infertile patients under the age of 35. The IUI response with any of these combinations is better if woman is at a younger age. So unstimulated IUI does not significantly increase the pregnancy rate. So never go for unstimulated cycles. There is nothing called natural cycle IUI. You may be getting hardly 1 follicle, that may not be synchronizing with the endometrial blood supply, and that is no use just giving the trigger injection and doing IUI, because doing IUI also gives her some cost. She'll be spending for that IUI. So it is not just IUI that is going to give her success. It is all the factors which I'm going to mention, like superovulation, preparing the endometrium, timing of IUI, the semen sample preparation. There are so many things that all do give a collective success rate. CC IUI gives only 5 to 7% pregnancy rate per cycle, even after 7 cycles, which is almost near to the natural pregnancy or unstimulated IUI cycles. Probably it has become obsolete, I can say. The follicular stimulation with HMG is more effective than CC alone, which I have already mentioned in my previous slide. The pregnancy rate obtained with the CC alone was half that obtained with HMG, and that is negligible. IUI with ovarian stimulation is the most performed option, and most of us do that. IUI ovarian stimulation, one should not forget about certain small risks like multiple pregnancy and OHSS. Both multiple pregnancy and OHSS in IUI may not be in our hand. That is, the prevention of these complications may not be in our hand, unlike the IVF cycles where we break the cycle and we do the frozen embryo transfers. The gonadotrophin antagonist, does it have any role in IUI cycles? Most probably no. The routine use of gonadotrophin antagonist in COH, that's controlled ovarian stimulation with IUI protocols, in terms of chances of success, not really recommended. Some people do say that it gives around 3 to 4% higher success rate, like say it's around 20-25%. They say it's around 27-28%, and it is not a proven fact according to many studies. Probably it has some kind of role which will be friendly to the clinician. In the sense, it could allow a flexible timing of the HCG injection and IUI, so that it avoids you working in the weekends. So when the patient is coming from a far off place, you may not be. It makes situation like the patient friendly, in the sense you may not have to scan her daily, because you have given anti for 2 to 3 days. Probably you can skip 1 or 2 scans instead of doing daily scans when she's coming off from far off places. So social factors are more takes more advantage than the clinical facts as such in considering the role of GnRH antagonist. Now, which are the cycles I was telling about previously that we should cancel? Probably like when there is a hyper response, that is more than 3 follicles which have grown beyond 16 mm, or 8 follicles which have grown beyond 12 mm. There are multiple follicles which we see are more than 12 mm, that is they are going to grow. The other end of the spectrum also is important, like certain cases, probably like PCOS, or a woman with a very poor ovarian response or a diminished ovarian response, where the follicles just do not rise, they just do not get stimulated, or in spite of pouring HMG injection or FSH, absolutely no response. This also happens, but these are the women one has to be cautious, because after some time, especially PCOS cases, after few days, when you have forgotten about her, when you have stopped calling her for scan, she may come with the accumulative effect of your gonadotrophin, which has resulted in OHSs. So these are the cases where sometimes the follicles do not respond in the beginning. You're given enough number of doses, daily injections. She comes one day, say after 2 weeks or 3 weeks with OHSs. So one should call her when you have this in mind, say after 1 or 2 weeks for a scan to monitor her ovaries. Now coming to the trigger part, the plan HCG, most of us do in IUI do give HCG injection. So it depends upon the stimulation protocol. Is it unstimulated? She has just come to your clinic, you scanned her, you've seen nice one follicle, which you think that is a dominant follicle about to rupture, you will give HCG injection. But the size of the follicle should be, if it is unstimulated, cycle around 22 to 24 mm. If you have given clomiphene, it's around 20 to 22 mm. If you have given gonadotropin, probably a little early also would do. To correctly time HCG, some people do take the help of Doppler. Definitely this will increase the success of IUI, because this will give additive beneficial facts. Like if the Doppler shows perifollicular flow of the dominant follicle, that is this about 70% of the circumference of the follicle is with good blood supply, or the resistance index is less than 5 and PSV more than 11, probably this is a better follicle, which is going to give me a success. The trigger injections, these are the 3 trigger injections: urinary HCG, IM 5,000 or 10,000, depending upon what you see in the sonography about the ovarian picture. RHCG is a 250 microgram subcutaneous, because it is RHCG. Agonist also is a trigger, though it is more popular in IVF cycles. Suppose you think that she's going to over respond with HCG, you are scared of OHSS, PCOS kind of follicles, you may give GnRH agonist also, though it is less popular compared to HCG. This is just a gist of the slide is bit busy slide, and please excuse me for that, but it just says that just look at the bottom line. It says all the secondary outcomes analyzed showed no significant difference between the treatment groups. That is, any kind of trigger you give, ultimately the result is almost same. They've compared between HCG versus agonist, recombinant versus urinary HCG, etc., etc. Now, so ultimately 3 important things, and what are they? So 1 is for the optimum stimulation, 2 to 3 follicles. We are not greedy. We don't want more than that. With the 18 to 19 mm size follicles, including both the ovaries, I'm very happy. Endometrium around 8 mm thickness, and trilaminar endometrium more than the 8 mm. It is the look of the endometrium that matters to us. Then IUI between the cycle day 13 most of the times and day 16, because that many days of stimulation is enough for us, and 36 to 40 hours from the HCG injection or whatever trigger you have given. So these are the 3 important facts. Now, what are the instructions we give to the male partner? All the slides are ultimately focusing on how to increase the success of IUI. What are the tips and tricks I can contribute to improve the success of IUI? So this is also another important factor, like what are the instructions I should give to the male partner, especially if it's a first IUI cycle, they may be absolutely ignorant of what he is supposed to do. So it starts much before. That is, I should tell him that it is 2 to 3 days abstinence and not more or less than that, for the facts well known to all of us here. The sample should be obtained in the center itself to prevent the complications. As you know, that somebody else's sample, mixing of sample, identity of the sample, whatever we say, and it should be collected by masturbation at leisure and ejaculated into the clean, wide mouth disposable container, what we have given in the center itself. It should not be collected how? 1, at home, 2 through coitus interruptus, through collection into the condom. So these 3 things are no to him. So at the center, what are the things that are primitive things, what are necessary? It should be, the center should have a private room near the laboratory. It should not be a general ward with the curtains in between, one delivery patient sleeping there, the surgical patient sleeping here, and one bed given to this man. Probably he will not be able to give sample at all with that atmosphere around. The correct identification of the sample with the complete name, not only the name, age and code number. The code number also is equally important, because sometimes the name and the age may match and sample may get mixed. So may need help sometimes to collect the sample. Complete sample should be processed, not just a partial. Like if he has given 2.5 ml, 3 ml, complete sample should be processed. Specimen container to be placed. This is another important factor, especially when the center is very busy. The sister will be wandering around here, there, many patients who will be attending to other ward patients also. So this is very, very important, because specimen container to be placed in the incubator. The temperature is very, very important at 37 degrees, even before it is processed. So the sample should get liquefied at 37 degrees centigrade only. So why should I prepare the semen? Why cannot I put the raw sample inside the uterus? Because it is very much mandatory before IUI, because the semen preparation selects a population of highly motile, not only motile, it's a morphologically normal sperm with a high fertilizing capacity, and that is the exact motto why we want a semen to be processed. It not only processes and removes the seminal plasma, debris, prostaglandins, and unwanted things, it also improves the sample. The quality of the sample is improved because we are going to put some media into that, so which will improve the fertilizing capacity. It improves the motility and promotes the capacitation of the sperm. So the ideal sperm preparation technique should be quick. It should be easy, because we are thinking of the small centers. We are not talking of the hi-fi IVF centers. So it should be quick, easy, and cost effective. It should isolate as many as healthy, motile, and morphologically normal sperm, because the morphologically normal sperm are the only ones which have the capacity to impregnate. Suppose the pregnancy happens with abnormal sperms, that is morphologically abnormal sperm, she is definitely bound to abort that pregnancy. So minimum sperm damage, because the effect also effectively eliminate the dead sperms, leukocytes, and unwanted material. So ultimately, the advantage of all this would be the bottom line statement, that is, it will reduce the reactive oxidative species in the sample. So semen preparation for IUI, what are the methods? The one is the swim up method, and second is the density gradient. These two are very popular methods, and simple washing sometimes we do when we think that the microscopic appearance shows that the sample is fairly clean and you want to freeze the sample. The simple washing also used sometimes. So swim up if normal or near normal semen. Density gradient if the oligospermia, asthenospermia, teratospermia, because density gradient gives us the good sperm. So density gradient is the best selection. Is most of the times, at least many of the IUI centers bank on density gradient method. This is a favorite method for many of the andrology technicians and as well as the gynecologists. The best selection of the good quality spermatozoa, giving good separation from other cell types and debris. So if you want to remove the debris as well as get a good quality sperm, probably this is one of best of both the worlds like. So a sample two-step discontinuous density gradient with the 40% density top layer and 80% below is the one that is used most of the times. So using DG method, that is a centrifugation, usually results in a fraction of a highly motile spermatozoa, and that is what we want. Okay, now something else. All men with elevated seminal white blood cells should be evaluated for a genital tract infection, because we all do the semen analysis much before IUI. So you have an idea how his semen sample shows, how does it appear. So in that case, if there is, it should be evaluated for a genital tract infection or inflammation, and semen culture should be performed and given a suitable antibiotic before you collect the sample for IUI. Unexpectedly, approximately 80% of the leukocytospermic samples are microbiologically negative, and we are happy about that. So now the processing is done. Now, how should be the post-processing report? What should the post-processing report contain? What are all the facts one should mention, and we as the inseminating doctors should check? Man and his wife's name, age, and the code number again, the period of abstinence, date and time of collection, any difficulty in collection he had, how did he collect, the time interval between the collection and start of the procedure. The semen parameters affecting IUI success are: one is count, all of us know, second is motility, and third is morphology. These three are very, very important factors which affect the IUI success. An average post-wash total motile sperm count, what we call as TMSC, of 10 million is the threshold value for IUI success. More than 10 million total motile sample post-wash, I am happy because success is reasonably good, on par with any other IUI success rate. At least 5 million motile sperm should be present in this IUI semen sample for reasonably good result. Bottom value should be at least 5 million. This is a study which had almost 50,000 IUI cycles, and that concentrated on the pregnancy rate related to the post-wash sample. So one side, it is the TMSC, that is after post-wash sample report, semen report, the pregnancy rate per cycle. If it was less than 1 million, then total motile sperm, pregnancy rate was 2 to 5%. It is too less, because less than 1 million, we don't consider at all. 4 to 5 million, 6 to 11%. 5 to 9 million, it was around 15%. 9 million, or what, as I told in the previous slide, at 10 million, it's around 20 to 25%, and that is the IUI result worldwide. So total motile sperm count cutoff value minimum should be 5 million. That is a post-wash. If less than 5 million, don't consider for IUI, because you will be wasting his time and money. Counsel them for ICSI. Other sperm parameters, that's a post-wash. The previous slide told about the count. I also told about other two factors, that is the motility as well as morphology. Coming to the motility, it should be minimum 50% motility. But many of us, when the andrology technician says the sample is ready, when he puts a drop under microscope and we check, most of the times we see that there are more than 90% are good forward moving sperm. So sperm morphology using strict criteria, that is a WHO criteria, cutoff value should be minimum around 4 per 100 is normal. I'm sorry. So what are the keys to success in the andrology lab? One is collection on site, very, very important. Preparation, all the slides which I explained previously, the different methods. Then quality control, equally important. Regular and complete documentation. MC Patel sir is very, very familiar, and he reiterates his facts always, and I abide by all this. The regular and complete documentation and auditing, very, very important. Now the andrology lab is over. The sample is handed over to us, that is the clinicians. So now we have to think when the timing of the IUI should be done. How critical is that? Majority of the studies said IUI is done about 36 hours following the HCG administration. Insemination of at least 36 hours after ovulation is associated with increased pregnancy rate compared to IUIs performed less than 36 hours. So 36 hours. So pregnancy rates were optimum between 32 to 40 hours after HCG trigger, probably a bit wider range here. So now coming to the number of inseminations, many of us do have this doubt lurking in our mind many of the times. So there are two slides on this. Main objective in the IUI is to time the insemination as near to the ovulation as possible. Ovulation normally occurs 40 to 45 hours after the onset of LH surge, that is the upward phase of the LH, because it has got a plateau also. Theoretically, there are two inseminations better, theoretically, because all follicles do not ovulate at one time. As when we scan, one will be 16 mm, one will be 18 mm, one will be still sitting at 14 mm, coming slowly. So all follicles do not ovulate ovulate at one time, and they do so in waves, and thus ovulation may not be synchronized after HCG. So cover from all the sides, like cover all the follicles which are ovulating. Single IUI may miss later released cohorts of oocytes. So they want to do 2 IUI. This consideration led many to carry insemination twice at the interval of 24 hours around the time of ovulation. So when you do double IUI, it showed no significant benefit over single IUI. That is like first IUI at 24 hours of the trigger, and second at 48 hours of trigger. But double IUI has advantage in male factor infertility. Note this point, please. So double IUI has the advantage if the semen sample is very poor. Meta-analysis included RCT's randomized control trials of 1,785 women, said single at 36 hours, that is the first IUI, and double, that is the second at 20. If it is a double IUI, single IUI at 36 hours, and if you are doing double IUI, one at 24 hours and the second at 38 to 40 hours. So the pregnancy rate increased with double insemination if there was a male factor problem. TMC less than 5 million, but again, it will not be very good like more than 10 million, but slightly better probably. Otherwise, double IUI showed no extra benefit. So it is only if there is a male factor problem, then you can consider double IUI. Coming to the intra insemination, what are the other advantages? Like it gives more follicles, and it is done at the time of rupture. The processed sample is placed inside the uterine cavity, check the endometrium, all that is fine. These are all the advantages. You are given best of all the possible situations to her. Other than that, it has few other advantages, like it overcomes the vaginal acidity. This is comparing to the natural coitus. It overcomes the vaginal acidity, cervical mucus hostility, anatomical defects of the vagina and the cervix, and sexual performance problems. Now coming to the technique, all of us know this: semi-filled bladder, sterile wash, clean the cervical mucus if it is too much, atraumatic insertion, never touch the fundus, 0.5 ml. All of us don't go till the fundus because the cannula are designed so well that you have a guard and it never goes till there. Then plunger, push tightly, and once you finish everything, remove it slowly and tell her to sleep for 15 minutes. These are all the instruments, as all of us know. Coming to, I have few more slides, that's all. Now coming to the difficult IUI, insemination is easy in many of the cases, probably 4 out of 5. But sometimes when you are doing IUI, you are caught unaware of difficult cases. You have been trying. Probably sometimes it so happens that your HSG was normal, your hysteroscope also went so easily, but IUI becomes difficult. So it sometimes really happens. Say this, what are the signs of this difficult IUI? It's a greater resistance during the catheter negotiation, because many of the catheters are so soft and so supple. They're so patient friendly, so semen friendly. So they may be really so much soft that they may be bending at the internal os. So there is a greater resistance at the internal os. The blood in the catheter tip, we are not happy. How are you going to manage? How are you going to avert these situations? Use a harder tip catheter, or sometimes what we do, like for IVF, use the one with the inside guide wire, or cervical dilatation sometimes may be needed. Definitely we do not advocate this, because this is going to result in some amount of blood. Bleeding will start and going to make the situation messier. Use of trans-abdominals can help, because you will know the direction of the cervix, the internal os, how your catheter is going, etc. Use of tenaculum or simspeculum sometimes. So in difficult cases, semi-full bladder, not a very full bladder. Suprapubic pressure may sometimes be necessary to align the uterus to the cervix. Keep the cervix centrally in the vagina using a bivalve speculum, so that the blades itself you're going to manage so that the cervix os is staring at you. The slight traction on the cervix with the Alice, probably just a one catch and not the complete Alice catch, just to pull so that the uteral cervical angulation is corrected. This is only when you have difficult cases I'm talking about. And prior hysteroscopy and cervical dilatation should be done before next IUI. You have tried this IUI, became very, very difficult. Don't do the next IUI just like that. Finish off whatever other things. Sometimes even the Nabatean cyst at the cervix, or sometimes a small fold in the cervix. Maybe we may be, because it's a blind procedure, we may be going and hitting that again and again. That yields blood. Then we will continue to do that. We will be again hitting that, and all that becomes a messier situation. So the ultrasound guidance, what is the role of the ultrasound? It is guided, ultrasound guided IUI has not been found to increase the pregnancy rates according to many studies. It's useful only in difficult situations, measuring the uterocervical angle with the ultrasound. That's how the cervix is, the relation of the cervix to the angle of the uterine body with the ultrasound before IUI, and molding the catheter accordingly. Sometimes we may have to bend the catheter, take it in the posterior direction. Once the os, we touch the internal os, then we push it, turn it 90 degrees and make it anteverted catheter direction. So these things probably may be more known, or we will be visible using the ultrasound. So is bed rest necessary? Immobilization in the supine position after IUI could prevent the direct loss of a large percentage of the spermatozoa and improve fertility cases. Probably a theory part. 10 minutes of bed rest after IUI has a positive effect according to certain studies. Women undergoing IUI should have 10 minutes rest after the procedure, not more than that. 4 vital parameters for success then would be: 1, the semen parameter itself, that is pre-processing. So then is the stimulation protocol, then how you are preparing the sample, ultimately how good the sample became after the preparation, then the insemination timing as well as the technique. So these are the 4 important parameters that result in the success of IUI. So IUI pregnancy rate is enhanced by shorter intervals from the semen collection to the sperm wash. The technician should not come after 1 hour after the patient has given sample. Then again from the sperm wash to IUI. I should not delay my procedure of doing IUI after the andrology technician has kept it in the lab, and I should not come after 1 hour to insert inside her. How many cycles I should do? It's around 3 to 6 cycles. Pregnancy rate significantly lowered after continuous third IUI, irrespective of the ovulation induction. This is again one important factor in counseling, because we should explain to the patient before we take her to the first cycle itself, because second or third cycle time she may be having another social engagements, like wants to go to the village or a marriage function, not able to get it done, etc. So we have to explain to her that it's better to do continuously 3 cycles together, one after another, and that gives the maximum success result. About 70% of the IUI pregnancies occurred in the first 2 cycles. That is, whatever happens out of that, 70% do happen in the very first 2 cycles, and maybe about 15% more if you do another 2 cycles. According to INS studies, 6 cycles of ovulation stimulation, ovarian stimulation IUI is still cost effective compared to direct IVF in couples with unexplained infertility and mild male factor. Having everything nice and fine there, probably you can go for 6 continuous cycles of IUI. That's what they say. The higher multiple pregnancy rate is still a major problem with IUI in gonadotrophin stimulated cycles, and it's around 10 to 40%. I have not come across up to 40% in my practice. Anyway, the recommendations with withholding the HCG trigger and cycle cancellation when more than 3 follicles of 16 mm. This is about the complications. Now coming to the last aspect, that is the luteal phase. Should we support? Yes, we should support with the progesterone. And what are those progesterones? Either vaginal progesterone of 200 milligram twice a day or 400 at bedtime, or the oral progesterone, that is a dydrogesterone 10 milligram orally twice a day till we get the result. There is no difference in pregnancy rate or live birth rate in the use of either vaginal micronized progesterone or oral dydrogesterone according to many studies, but after the Lotus trials, Prism trial, etc., probably everyone is inclining towards the oral dydrogesterone compared to the vaginal micronized progesterone. So coming to my last slide, the summary or the take-home message would be: the gonadotrophins give maximum success rate compared to oral ovulogens in IUI cycles. Density gradient method is best to get the quality sperm. Double insemination is indicated only if there is a male factor problem. Antagonist is only addition may improve the sexes very marginally, but more of convenience to either doctor or patient or combined. Meticulous IUI performance is crucial. Luteal phase support is must, and many do start the luteal phase support one day after IUI if you have given the HCG trigger. Success rate with IUI falls after 6 IUI cycles. Thank you. I stop here. At the end of my presentation, I again request the presidents and secretaries of the society to kindly vote and support for me because I'm contesting for the post of chairperson, Clinical Research Committee, FOXY. Thank you.
Thank you, madam.
Yeah.
Pramoda.
Sir. Thank you, ma'am. That showed your presentation showed your vast clinical experience. Though many of us are aware of the things you have presented today, most of us miss some or the other point in our daily practice. Thank you, ma'am, for putting us in right direction. At least from now, we are thankful so that we won't miss even the small things in our day-to-day practice. Thank you, ma'am.
Thank you, Dr. Pramoda. Thank you, Umashankarsa.
Thank you, madam. From now, we move on to the next session. We have a speaker is Dr. Sirisha and chairperson is Dr. Sridevi. Dr. Sridevi is assistant professor. She is UG at Kurnool Medical College, PG at SVMC Tirupati. She is a gold medalist. Got Best Doctor Award 2 times from District Collector. Presented papers at state and national conferences. The secretary of Ungo Lobs and Gynae Society. Presented paper at international conferences virtually. Madam Sridevi, madam, are you there, madam?
Yes, sir. Good evening, sir.
Good evening, madam. Yes, madam. Please.
I am very happy to be a part of this webinar, sir. ABHYAS.
Yes,
The serial webinars are going on, sir. Very nice, sir, to be a part of this. Dr. Pramoda, I am very happy to see her. She is my junior at Kurnool. Hi, Pramoda.
Hi.
Okay. Sir, please show me the
yes, CV of
CV, sir. Yes, sir. Dr. G. Sirisha, she did her MBBS and DGO, studied at NRI Medical College, Mangalgiri, Ashram Medical College, Elur. She is working as a consultant at Ahalya Nursing Home, Guntur, field of interest is fetal medicine. We welcome you, madam, for this webinar.
Thank you, madam. Good evening, everyone. Thanks for giving this opportunity. Today, my topic is UTI in pregnancy. The urinary system.
Share the screen. Please share the screen. Make it big.
Make it full screen, ma'am.
Full screen. Full screen. Press the. I need to say screen. Down there is a TV button right there. Slideshow button.
Okay, sir.
Again, share the screen. Yeah.
Ma'am, please click on slideshow button.
Slideshow button.
62%, the left side of that 62%, you see a button, no?
Down you see. Small button is there, like TV button is there.
Next to that 62%.
Kinda there is left and minus and plus are there, right? In the right hand, you can see that.
Ma'am, I have requested for remote control. Could you please accept it? I will make it full screen. Okay, ma'am.
Yeah, you start. You again share the screen once again, Sirisha.
Okay, sir. Okay, sir.
Okay, you start your presentation.
Okay, thank you. The urinary system, it includes the kidney, renal pelvis, ureters, urinary bladder, and urethra. The anatomical changes in the urinary system during the
Started moving. You are in the first slide only.
Yes, ma'am.
Okay. Okay, please continue.
Okay, ma'am. The anatomical changes during the urinary system are there is a dilatation of the pelvic axial dilatation due to the presence of the placental progesterons and compression of the ureter by uterus at the level of pelvic brim. The pelvic axial dilatation is up to the 15 mm on right side, 5 mm on left side at the term of pregnancy. Because of the changes during pregnancy leads to increased frequency and severity of the urinary tract infections. The dilatation of the ureters and renal pelvis is the maximum by middle of second trimester. The renal hemodynamics.
Ma'am, your slides are not moving, ma'am.
Yeah, that's what I meant.
We are not able to see your slides, ma'am. We are able to see your first slide.
Yeah, that's what I said.
You share it from another computer. Take over.
Is it visible, ma'am?
Yes. Ma'am, please click on enable editing also, ma'am.
Okay.
Yes, ma'am.
Is it fine, ma'am?
Yes, yes, ma'am.
Okay, thank you. The anatomical changes in the urinary system are pelvic axial dilatation due to the effect of the placental progestins and compression of the ureter by uterus at the level of pelvic brim. Because of the changes, the frequency and severity of the urinary tract infections increases. The dilatation of the ureter and renal pelvis is maximum by middle of second trimester. The renal hemodynamics are, there is an increase in renal plasma flow, increase in GFR by 50% higher than the non-pregnant state, and changes in the tubular reabsorption of glucose, sodium, amino acids, and uric acid. The serum creatinine decreases from a non-pregnant level of 0.8 to 0.5 milligram per deciliter by term. The renal tubular changes are the glucose excretion increases in all pregnant women. However, gravids with repetitive glycosuria should be screened for diabetes if not exist already. And in pregnancy, there is an increased excretion of the protein and albumin with the upper limit of 300 mg of proteinuria and 30 mg of albuminuria in 24-hour period. The UTI the urinary tract infections are frequent problem in women with pregnancy. The symptomatic lower UTI has been shown to occur up to 20% of pregnant women due to the presence of physiological adaptations in renal tract. The UTI often occur during the first trimester. It is more frequently seen in the multiparous women and diabetes. The terminology used in the UTI are bacteriuria. It is the single organism of 10^2 colony forming units per ml. The asymptomatic bacteriuria is defined as the without symptoms, the single uropathogen of greater than 10^5 colony forming units in post-void midstream clean gas specimen in women with no symptoms. The urinary tract infection is defined as presence of symptomatic women with presence of single uropathogenic greater than 10^5 colony forming units. However, some women with lower counts may also have acute symptoms. The recurrent UTI is defined as the symptomatic infection that follows the resolution of previous UTI, generally after treatment. Recurrent infection may be relapse or reinfection. It may be relapse, it is caused by same organism. Reinfection, it is caused by different organism. Pyuria is defined as the presence of greater than 10 leukocytes in high power field of unspun urine sample or greater than 50 leukocytes of high power field in a sperm urine specimen. The predisposing factors for the urinary tract infection during pregnancy are the physiological dilatation of urinary tract, urinary stasis, presence of vesicoureteric reflex, and altered urine pH, higher incidence of glycosuria. The etiological agents which causes the urinary tract infections are most commonly community acquired is E. coli, hospital acquired is the Klebsiella and the Enterobacter species. Other organisms are the Proteus, Enterococcus, Staph aureus, Staphylococcus, and Uroplasma, Mycoplasma, Chlamydia, and Pseudomonas aeruginosa. The pathophysiology is the urinary tract infections are most commonly caused by ascending infection due to the short length of urethra and proximity to perineum. Most of the 90% of the urinary tract infection is caused by E. coli, which causes the non-obstructive pyelonephritis. The associated conditions which causes the complication of urinary tract infections are the structural causes are urolithiasis, malignancy, ureteric stricture and urethral stricture, bladder diverticulae, renal cyst, fistula, and urinary diversions. Functional causes are the neurogenic bladder, vesicoureteric reflex, voiding difficulties. Origin bodies are indwelling catheter, ureteric stent, nephrostomy tube. Others are the diabetes mellitus in pregnancy, renal failure, renal transplant, immunosuppression, multi-drug resistance, and hospital-acquired infection. The asymptomatic bacteria is noted in 2 to 7% of the pregnant women. Screening done in all pregnant women. It is defined as the greater than 10 power 5 of colony forming units of single uropathogen in post-void midstream clean gas specimen in women with no urinary symptoms. Changes in the urinary tract during pregnancy favors the progress of asymptomatic bacteriuria to lower the UTI and eventually acute pyelonephritis. The asymptomatic bacteria is associated with the increased risk of preterm deliveries and low birth weight. The antibiotic treatment reduces the risk of pyelonephritis and incidence of preterm delivery and low birth weight. The antibiotic treatment used for the asymptomatic bacteriuria, which is single dose treatment, is amoxicillin 3 gram, ampicillin 2 gram, cephalosporin 2 gram, and nitrofurantoin 200 mg, and trimethoprim and sulfamethazolam 320 and 600 micrograms, which is not used in the first trimester due to folate antagonistic. And 3-dose course is amoxicillin 500 mg TID, ampicillin 250 mg QID, cephalosporin 250 mg QID, and ciprofloxacin 250 mg BD, levofloxacin 250 mg or 500 mg OD, nitrofurantoin 100 mg QID or 100 mg BD. The treatment failures, the nitrofurantoin dose is 100 mg QID for 21 days. For any bacterial persistence or recurrence, the nitrofurantoin 100 mg at bedtime from pregnancy till the delivery. The clinical presentation of the acute cystitis and acute pyelonephritis is acute cystitis is most common, affecting the 2% of pregnant women. The acute pyelonephritis is 0.5 to 2%. The symptoms in acute cystitis is presence of the dysuria, increased frequency of urine, urgency, and suprapubic pain. In acute pyelonephritis associated with these acute cystitis, there is a presence of fever and nausea, vomiting, myalgia, headache, confusion. The signs in the acute cystitis are suprapubic tenderness. In acute pyelonephritis, there is presence of tachycardia, hypotension, and tenderness in the costovertebral region, most on the right side. The urinary tract complications are the maternal complications include pyelonephritis and preterm delivery, anemia due to toxins-induced hemolysis, and pregnancy-associated hypertension, sepsis, and respiratory distress syndrome due to the toxins released by the organism, and pulmonary edema, which is associated with the beta agonistic for tocolysis and renal dysfunction. Fetal risks are preterm birth and low birth weight. The investigations are complete urine examination and urine culture and sensitivity, positive nitrate dipstick test and leukocyte esterase test are also indicative of UTI, and RFTs are sending to know the any acute kidney injury. Ultrasound is done in case of any abscess, urinary tract abnormalities, or renal stones. Urine culture, a midstream clean void sample obtained after washing the introitus with tap water without soap and water is inoculated. A selective culture media such as a McConkie within 20 minutes. If it is delayed, urine must be refrigerated to 4 degrees. Urinary culture done in low risk women, a single culture of midstream urine at booking in first visitor second trimester. In women with the risk factors, they need cultures frequently. The treatment used in the acute cystitis are amoxicillin 500 mg BD 3 to 7 days, nitrofurantoin 100 mg BD 3 to 7 days, the ciprofloxacin, which is the cephalosporin first generation drug 500 mg BD or TID 3 to 7 days, amoxicillin 500 mg BD 7 days, and cephalosporin, which is the third injection cephalosporin 100 mg BD 7 days. For the recurrent cases, the management includes prophylactic antibiotics should be given to women with recurrent bacteriuria or infection. The choice of antibiotics is determined the urine culture. The drugs used are the cephalexin 250 to 500 mg nighttime or postcoital. Nitrofurantoin is 50 to 100 mg nighttime or postcoital for 21 days. Amoxicillin is 250 mg nighttime or postcoital. Management of UTI to pregnancy investigations are the women with history of recurrent UTI undergo ultrasound to look for the renal anatomical abnormalities, persistent renal stones, Women with the recurrent cystitis have their urine culture monthly. Treatment: women with a history of postcoital cystitis, postcoital single dose cephalexin 250 mg or nitrofurantoin 50 mg can reduce the infection. The urological management for renal stones prior to pregnancy. These women may be on regular antibiotic prophylaxis continued throughout the pregnancy. For UTI, management of UTI, it includes analgesics, antibiotics, 4 to 5 dose of antibiotics, and treatment with the effective to E. coli. Avoid the trimethoprim in first trimester due to folic acid antagonistic, which causes the fetal anomalies. Lower urinary tract symptoms with pyuria is accompanied by sterile urine culture may be caused due to Chlamydia trachomatis. Azithromycin is the effective. Patient with UTI, the labor and delivery is normal management of labor and delivery. Continue antimicrobial therapy to complete course if started before labor. In postnatal, adequately treated UTI should not be complicated the puerperium. Imaging of urinary tract should be considered in complex or recurrent infections if not done in pregnancy. Acute pyelonephritis. Acute pyelonephritis, it involves the upper urinary tract. Pyelonephritis is mostly unilateral, most on the right side due to the dextrorotation of uterus. The fever and chills are mostly associated with this, and patients have aching pain in 1/3, both in lumbar regions, and nausea, vomitings may worsen the dehydration. Tenderness usually can be elicited by percussion on the one or both the costovertebral areas, more on the right side. If the infection is acute pyelonephritis is suspected, a urine sample obtained by the catheterization may be prepared to avoiding the contamination from the lower genital tract. The urinary sediments contain mainly leukocytes, frequently in the clumps and numerous bacteria. Urinary activity from endotoxin is common and related to fever severity. In one study, women with pyelonephritis average 5 contractions per hour at admission, and it decreases to 2 per hour within 6 hours of IV antimicrobial administration. Complications in the acute pyelonephritis are hemolytic anemia, thrombocytopenia, decreased glomerular filtration rate, and acute respiratory distress syndrome, uterine contractions, endotoxic shock, and hypothalamic instability. The investigations are complete blood picture, serum creatinine, blood urea nitrogen, LDH, and serum electrolytes, and CUE, urine culture, and CUE. And chest X-ray and ABG should be performed in presence of any respiratory distress syndrome. It needs hospital admission and rehydration, IV antibiotics for 24 to 48 hours, followed by oral therapy 10 to 14 days. Recurrence of pyelonephritis in pregnancy is 6 to 8%, and therefore patients should be placed in one of the preventive regimens of antibiotics for remainder of their pregnancy. Venous thromboembolism prophylaxis. Antibiotics used in pyelonephritis are ceftriaxone 1 gram daily, ampicillin 1 gram QID, gentamicin 3 mg per kg daily, and piperacid piptas 3.375 grams QID, and meropenem TID. Follow-up for urinary tract infection patients are, regardless of regimen given, the recurrence rate is approximately 30%. They may indicate the covered upper UTI and need for the longer therapy. So initial therapy, periodic surveillance is necessary to prevent the recurrent UTI infections. The midstream urine culture of 1 to 2 weeks after the antibiotic course is completed to ensure the eradication. They should have urine culture monthly until delivery, looking for the recurrence. To prevent the recurrence of infection, non-pharmacological methods used are usage of the cranberry products, aquapuncture, probiotics, behavioral modifications, and pharmacological methods are use of low-dose, nocturnal, or single-dose postcoital antibiotics. Thank you.
Thank you, Sirisha.
Thank you, sir.
Madam, will you give your comments, madam?
Sirisha very nicely explained regarding the anatomy and also antibiotic dosages. Thank you very much. Sir, other speakers also very nicely explained, Rekha ma'am and one more ma'am, sir. Thank you, sir. Thank you.
Thank you, madam.
Thank you, sir.
So we
Thank you,
have
madam.
Priyanka Roy with us. Priyanka Roy, have you joined Priyanka? Monica? Priyanka Roy will join us at any moment. So can I have CV of Priyanka Roy?
Yes.
Monica, what is the status of Dr. Priyanka?
Sir will join in a minute, sir.
Okay, okay. Meanwhile, I'll read the CV of Dr. Priyanka.
Yes,
He is
sir.
today as a guest of honor. He is an Indian representative of WATOG, FIGO 2018 and 21. National Coordinator, Parenteral Committee, FOXY. East Zone Coordinator, Infertility and Maternity Committee, FOXY. Joint Secretary, Siliguri OBG, Organizing Secretary, East Zone, UA, FOXY 2020. Published more than 60 articles, international and national journals. Authored 15 chapters, peer reviewer of various journals. Presented greater than 50 articles in various conferences. And to his awards, is gold medalist for topping MS University exams, FOXY Korean Award, FOXY Future Award, AOFOG Shah S. Ratnam Young Gynecologist Award, FOXY Dr. Kamini Rao Orator, FOXY Dr. Shanti Yadav Award in Infertility, FOXY IAC Sun Traveling Fellowship, FOXY Nimish R. Shilat Research Award. I think Priyanka has all the awards that the FOXY has. I think he will be joining us in a moment. And he has recently been elected as a ESAR committee member, and he is unopposed Public Awareness Committee Chairperson. FOXY has been elected recently. Dr. Rekha, madam, are you there? Yeah, Priyanka?
Yeah, I'm there. I'm there.
Yeah, Priyanka is joining, madam.
Yeah.
Thanks, sir.
Yeah, Priyanka, it's good to see you. We have read your elaborate CV. We have all the awards FOXY has given. You have one award given to you. It's very nice.
So thank you so much, sir.
Congratulations, first of all, for being unopposed Public Awareness Committee. I think the first conference as a guest of honor Public Awareness Committee chairperson, though not officially given, but you are our guest today.
He got two esteemed positions. One is ISAR and one is chairperson Public Awareness Committee. Hi, Priyanka. Nice to see you.
It's very nice.
Hi, so thank you so much for giving me this honor and opportunity. I'm very young to be a guest of honor right now, but I would really like to thank Dr. Umashankar sir, Dr. Rekha Rajendra Kumar ma'am, and all of you for giving me this opportunity and for being, and of course the APOGS, Venkateshwara Rao sir, and the whole team of APOGS for giving me this opportunity. Indeed, a great program with, of course, Dr. MC Patel sir being the chief guest, Dr. Danga ma'am, and Dr. Venkateshwara Rao. It's a pleasure to be sharing the chair with all the three stalwarts, and of course with the expert speakers and chairpersons. So thank you so much for giving me this opportunity once again. I'm right now in Chennai, already in your zone, traveling to Salem for the South Zone UA FOXY. So hopefully looking forward to seeing all of you in the next couple of days. Thank you so much for the opportunity once again.
Thank you, Priyanka, for your kind words. Yes.
Thank you so much, sir. And I would like to also wish all the best to Dr. Umashankar sir for his election, and Dr. Rekha Rajendra Kumar ma'am as well for the election. So all the best to both of you.
Thank you, Priyanka. Where are you flying from, Priyanka?
I just flew to Chennai. I'm right now in
Siliguri to Chennai directly?
Yes, Siliguri to Chennai. Yes, ma'am. Thank you. Thank you so much.
Yeah.
So we have our last session. Dr. Divya madam is slightly busy. She's a chairperson today from Rajmundry. She is the secretary of Rajmundry Optional Guiding Society. And today we have our speaker, Dr. Lakshmi Priya. Can I have Lakshmi Priya madam's CV, please? Yeah, she's a MSOBG, consultant gynecologist at AHYA IVF, and ABHYAS at Guntur Medical College, PG at Bhaskar Medical College, Hyderabad. She has completed MRCOG Part 1 and 2 and taking the Part 3, and she has presented many case reports on tuberculosis, endometritis, and congenital malformation and obstetric outcome. Her field of interest is infertility and laparoscopic surgeries. Dr. Lakshmi Priya, kindly take your session. Dr. Lakshmi Priya.
Sir.
Yeah.
Thank you so much, Dr. Umashankarsa, for giving me this opportunity. Good evening, sir. Good evening, sir, and all madams. Materials which are safe in pregnancy are penicillin, cephalosporins, erythromycin, and azithromycin. In penicillin sensitive individuals, and which are contraindicated antibacterials are aminoglycosides, which cause ototoxicity, tetracyclines cause teeth and bones deformity in the fetus, sulfonamides cause neonatal jaundice kernicterus in the fetus, chloramphenicol cause gray baby syndrome in the fetus, and quinolones like ciprofloxacin cause arthropathy, bone and cartilage damage. According FDA category, A category, which are human proven studies, there are no antibacterials in this category. And category B is animal proven studies, which are safety. In animal proven studies, the drugs are safe. These are penicillin, cephalosporins, carbapenems, clindamycin, erythromycin, azithromycin, metronidazole. Metronidazole, actually, it is awarded in first trimester, and nitrofurantoin, acyclovir, amphotericin B, ethambutol, these are category B drugs. Category C drugs are in animals. In human, there is insufficient human studies, but in animal studies, there are problems in animal studies. We have to use them only if the benefits outweigh risks. Like quinolones, chloramphenicol, clarithromycin, imipenem, linezolid, trimethoprim, vancomycin, rifampicin, isoniazid, pyrazinamide, fluconazole, caspofungin. And category D drugs, where animal studies showed there are contraindication. They cause side effects in animal studies, and they are tetracyclines, voriconazole, aminoglycosides. And category X is absolutely contraindicated in both human and animal studies. That is ribavirin. Actually, the drugs in first trimester, they usually cause teratogenicity, but in the 3rd to 9th month, they cause more functional effects. Except for all the organs are formed by the end of the 3rd month. So from the 3rd month, urogenital and central nervous system are still to be formed. So they cause more functional effects, like aminoglycosides cause nephro and ototoxicity, and salicylates cause increased risk of bleeding in fetal and maternal both. In for example, some drugs like macrolides, like example azithromycin, clarithromycin, erythromycin, they are category B and C drugs, and they cross the placenta in low amounts. And lactation, during lactation, erythromycin is compatible. And coming to tetracyclines, they are category D drugs, and they cause problems with teeth and bone and other effects. And in lactation, they are compatible with breastfeeding, and serum levels in infants are undetectable. Coming to sulfonamides, they are category C drugs, and they readily cross the placenta. During lactation, they are excreted into breast milk in low levels and should be avoided in premature infants, because these cause sulfonamides. They cause hemolysis in infants. And other thing, estrione, miscellaneous antibiotics like estrionam, category B drugs, and their lactation compatible. And clindamycin, it is category B drug, and lactation it is compatible. Then coming to fluoroquinolones, they are category C drugs, and they are not recommended in pregnancy, and they cause cartilage damage in fetus in animals and animal studies. And lactation, they are excreted into breast milk and limited data. Then coming to cephalosporins, category B drugs in pregnancy, and they cross the placenta during pregnancy. And in lactation, considered compatible with breastfeeding. And carbapenems like etapinum, imipenem, and meropenem, they cross the placenta, and there is very little human data. And in lactation, they are extruded into breast milk in low amounts. Unknown, there are only less studies on this carbapenem. And coming to some empirical antibiotic treatment for some specific conditions, like in asymptomatic bacteria, already as Dr. Sirisha ma'am told, first choice, it is in asymptomatic bacteria, the amoxicillin and cephradine are the first choice. And in penicillin allergy, the nitrofurantoin and trimethoprim are given for 5 days. Then in multi-drug resistant and persistent urinary tract infection, phosphomycin and nitrofurantoin are given for 7 days. Phosphomycin a single dose and nitrofurantoin 6 hourly for 7 days. And in recurrent urinary tract infection, gentamicin is used for recurrent and unusual cases. Then in acute pyelonephritis, IV aztreonam TID, and in extended spectrum beta lactamase positive organisms, IV temocillin 2 gram 12 hourly for 24 to 48 hours, followed by IV and oral treatment. And later we have to do urine culture and sensitivity, and we have to give the according drug for 7 days. And alternative drugs in case of penicillin allergy people, we have to give cephalexin 500 mg twice or thrice a day for 7 to 10 days, and cefuroxime 3 to 4 times per day. And in case of urosepsis, that is urinary tract infection with modified early obstetric warning score more than 3, first choice is IV meropenem 1 gram TID, and alternative IV gentamicin 5 mg per kg OD. In community acquired pneumonia, we have to give amoxicillin TID, IV oral or IV amoxicillin TID plus oral or IV azithromycin 500 mg 24 hourly. And in case of penicillin allergy non-anaphylactic type, we have to give IV ceftriaxone 2 gram 24 hourly and azithromycin 500 mg 24 hourly. And in case of penicillin allergy anaphylactic type, we have to give IV vancomycin 10 mg per kg 12 hourly, or oral or IV azithromycin 500 mg 24 hourly. And in case of severe community acquired pneumonia, that is rapidly progressive to acute respiratory distress syndrome and severe sepsis and hemoptysis, we have to prescribe IV benzyl penicillin 1.2 gram 6 hourly plus IV clindamycin 1.2 gram 6 hourly, or oral clindamycin 600 mg 6 hourly. In case of penicillin allergy, we have to go for IV ceftriaxone or clindamycin. And in case of anaphylactic type of penicillin allergy, we have to go for IV vancomycin and clindamycin. Then in case of maternal sepsis, like in cases of sepsis in pregnancy or chorioamnionitis or endometritis, peripartum maternal pyrexia, and sepsis following pregnancy within 6 weeks postnatal, and the postpartum sepsis or post-abortion sepsis, puerperal sepsis, and postpartum endometritis and sepsis of unknown origin. The first line is IV amoxicillin 1 gram 8 hourly plus IV clindamycin 1.2 gram 6 hourly for 40 to 72 hours, and IV gentamicin 5 mg. We have to give stat, followed by we have to send the culture and sensitivity, blood culture and sensitivity, and we have to give the treatment accordingly. And also if the organisms are ESBL positive, extended spectrum beta lactamase positive, then we have to go for IV temocillin 2 gram 12 hourly and IV clindamycin 1.2 gram 6 hourly for 48 to 72 hours, followed by the culture sensitivity report. And if the organisms are methicillin resistant staph aureus, and if there is penicillin allergy, we have to go for IV teicoplanin 12 mg per kg 12 hourly for 3 doses, then 10 mg per kg 24 hourly, and IV clindamycin 1.2 gram 6 hourly plus IV gentamicin stat dose, followed by culture sensitivity report. Accordingly, we have to treat the patient. Then if the organisms are known extended spectrum beta lactamase positive, then IV teicoplanin 12 mg per kg 12 hourly for 3 doses, then IV clindamycin and IV gentamicin stat. Cesarean section incisional wound infection, in case of incisional wound infection in cesarean section, we have to first choice is IV coamoxiclav 1.2 gram 8 hourly, or oral coamoxiclav 625 mg TID. Then penicillin allergy or MRSA positive, we have to go for IV teicoplanin for 3 doses, then 10 mg per kg 24 hourly. Then in cases of mild to moderate endometritis following vaginal delivery, we have to go for IV gentamicin 5 mg per kg for 48 hours and oral clindamycin 450 mg QID for 5 days. And in case of lactational mastitis or breast abscess, first choice is peroral flucloxacin 1 gram 6 hourly, And in case of penicillin allergy, we have to go for clindamycin, IV or oral. Then coming to in cases of organisms, in cases of MRSA positive organisms, we have to go for IV ticoplanin 10 mg per kg BD for 3 doses, then 10 mg per kg 24 hourly, or we can go for oral linezolid. But linezolid is used only if benefit outweighs risk. Then coming to amnio procedures like amniocentesis, antibiotic prophylaxis is not recommended in case of amniocentesis, and in cases of evacuation of return products of consumption after MTP or mid-trimester delivery, first choice is Coamox, IV Coamoxiclav 1.2 gram single dose. Alternative is penicillin allergy. In case of penicillin allergy, we have to go for IV metronidazole plus oral doxycycline 200 gram single dose. Then in case of preterm premature rupture of membranes or preterm pre-labor rupture of membranes, first choice is amoxicillin TID for 7 days or until the woman is in established labor. Then alternative, if they are penicillin resistant, we have to go for penicillin allergy cases, we have to go for azithromycin 500 mg 24 hourly for 7 days or until woman is in established labor. Then coming to cervical surplus, first choice is IV Coamoxiclav 1.2 gram single dose, IV clindamycin 1.2 gram single dose. Alternative, and coming to examination and anesthesia, IV Coamoxiclav 1.2 gram single dose. Alternative is clindamycin single dose with IV gentamicin single dose. In case of at a term, if there is premature rupture of membranes at term, at a term, actually to prevent early onset neonatal group B streptococcal disease, actually at term, if there is premature pre-labor rupture, routine antibiotic prophylaxis is not recommended. Antibiotic prophylaxis is recommended only if there is GBS positive organisms and prolonged rupture of membranes more than 48 hours and maternal pyrexia temperature more than 38 degrees. What is the intrapartum antibiotic prophylaxis for GBS is IV benzyl penicillin 3 gram start dose, then 1.5 gram 4 hourly until delivered. For penicillin allergic patients, we have to go for IV ticoplanin start dose and then every 12 hourly until delivered. Then if patient proceeds to have LSCS, we have to add gentamicin stat. And in case of premature rupture of membranes, and if routine antibiotic is not recommended for women in preterm labor with intact, if there is intact amniotic membranes, routinely not recommended. And if in case of preterm labor with the premature rupture of membranes, then we have to go for IV benzyl penicillin 3 gram start, then 1.5 gram 4 hourly until delivered. If the penicillin allergic, we have to go for ticoplanin start dose and then every 12 hourly until delivered, and we have to add gentamicin. Episiotomy repair following normal delivery, routinely not following normal delivery, it is not recommended. For uncomplicated vaginal delivery, antibiotic prophylaxis is not recommended. And in case of repair of 3rd and 4th degree perineal injuries, if the BMI is less than 30, we have to go for IV Coamoxiclav 1.2 gram single dose. And if BMI more than 30, we have to go for Coamoxiclav plus amoxicillin 1 gram single dose. Alternative to if they are penicillin sensitive, we have to go for IV clindamycin 1.2 gram single dose and IV gentamicin 5 mg per kg start dose. In case of forceps or vacuum delivery, first choice is BMI less than 30 Coamoxiclav, and if BMI more than 30 Coamoxiclav and amoxicillin. If there are penicillin allergy, then IV clindamycin and IV gentamicin. Cesarean section for elective and emergency cesarean, single prophylactic antibiotics only, usually 30 minutes before before skin incision. Single dose is recommended. Coamoxiclav 1.2 gram single dose in case of BMI less than 30 and BMI more than 30 single dose, and alternative is clindamycin. In emergency cesarean with PPROM or PROM over 4 hours or cervical dilatation more than 4 centimeters, then we have to use additional prophylaxis with IV azithromycin 500 mg single dose. High risk of if they are methicillin resistant staph or staph organisms, then we have to go for IV ticoplanin with IV gentamicin. And for after removal of placenta, routine not recommended, and routinely it is not recommended. In postpartum dilatation and curettage for return products, antibiotics is not recommended. Specific conditions like group A streptococcus, vaginal discharge in pregnancy or postpartum, usually group A streptococcus organisms. For that, amoxicillin, oral amoxicillin 1 gram TID for 5 days or cephalosporin 500 mg QID for 5 days, or IV benzyl penicillin 1.2 gram with IV clindamycin 6 hourly, and alternative is clindamycin oral or IV clindamycin 6 hourly for 5 days. Then coming to Trichomonas vaginalis, metronidazole 400 mg BD for 5 days. Actually, metronidazole is safe to use in pregnancy. Breastfeeding should be withheld during treatment and for 12 to 24 hours after the last dose to reduce infant because it crosses the lactation, it crosses the and enters into the breast milk. Vaginal candidiasis, acute vulvovaginal candidiasis, clotrimazole pessary 500 mg intravaginal at night for 7 days, and recurrent vulvovaginal candidiasis, for starting we have to give for 10 to 14 days clotrimazole pessary, and maintenance we have to give weekly 500 mg intravaginal weekly. Recurrent vulvovaginal candidiasis due to azole resistant candida, nystatin pessaries 1 lakh units intravaginally at night for 14 days or 14 days in a month for 6 months. Consider 14 days per month for 6 months. Bacterial vaginosis, first choice is metronidazole 400 mg followly for 5 days. Alternative, in case of breastfeeding, we have to go for intravaginal gel once daily at night for 5 days or intravaginal cream once daily at night for 7 days. Then chlamydia trachomatis or Neisseria gonorrhea, first choice is IM ceftriaxone 500 mg stat plus oral azithromycin 1 gram single dose. Alternative is intramuscular spectinomycin 2 gram single dose with oral azithromycin 1 gram single dose. In case of malaria in pregnancy, in case of severe malaria, complicated malaria, parenteral artemisinin is advisable. Artesunate IV or IM 2.4 mg per kg at 0, 12, 24, 48 hours, or artemether IM 3.2 mg per kg, 1.6 mg per kg OD. In case if it is not available, then we have to go for quinine infusion. We have to go for quinine salt infusion. In case later quinine 10 mg per kg plus doxycycline clindamycin for 7 days. In case of uncomplicated malaria, Plasmodium vivax. If it is Plasmodium vivax, chloroquine for 3 days with primaquine for 14 days. And if it is falciparum, northeastern states, they will go for artemether, lumefantrine and primaquine on day 2. And if it is other parts of India, then then artemether and sulfadoxine pyrimethamine 4 mg per kg with primaquine 0.75 mg per kg on day 2. And if it is mixed infection, we can go for ACT and primaquine for 14 days. Infective endocarditis prophylaxis, it is given only in conditions like prosthetic cardiac wall replacement and previous history of endocarditis and cardiac transplant recipients who develop valvulopathy and congenital heart disease, especially in unrepaired cyanotic heart disease and repaired with prosthetic material in the first 6 months and repaired with residual defect at the site or adjacent to the site of prosthetic material. Standard regimen is ampicillin, gentamicin and amoxicillin. And in case of allergic patients, we have to go for vancomycin and gentamicin, amoxicillin. If there is pyrexia in labor, that is temperature of more than 38 degrees, we have to do full septic screen, including blood cultures and midstream urine samples. Empirically, we have to go for IV amoxicillin 2 gram with IV metronidazole 500 mg, then IV amoxicillin 1 gram TID with IV metronidazole 500 mg TID until delivery. In non-severe penicillin allergy, IV cefuroxime 1.5 gram TID and IV metronidazole 500 mg TID until delivery. If severe penicillin or cephalosporin allergy, give IV clindamycin 900 mg TID until delivery. And add IV gentamicin immediately if the patient has high risk red sepsis, that is hypotension, which fails to respond to initial fluid bolus. And anti-tuberculous drugs, rifampicin comes under the category C, isoniazid and category C, pyrazinamide category C, and ethambutol category B drugs. These are then coming to multi-drug resistant TB, cycloserine category C, para-aminosalicylic acid category C, thionamide category C, fluoroquinolones, capreomycin category C drugs. And streptomycin is absolutely contraindicated because it causes ototoxicity, eighth cranial nerve damage. Capreomycin, ethionamide, para-aminosalicylic acid, teratogenic in animals, but no data in humans. Fluoroquinolones like levofloxacin, ofloxacin, moxifloxacin cause erosion of cartilage and arthropathy. These are first line. These streptomycin, amikacin, cycloserine, ethionamide, fluoroquinolones, capreomycin, these are all first line drugs. In case of fungal infection, Nystatin, the topical like nystatin category, topical nystatin is category B, clotrimazole category B, miconazole, terconazole, teoconazole, all these are category C. But in case of systemic use in pregnancy as limited to life-threatening fungal infections only. Like amphotericin category B, fluconazole category D, ketoconazole category C, itraconazole category C, and amphotericin B category B, flucytosine category C. With the systemic antibiotics, there are side effects like chronic high dose treatment in first trimester causes Antley-Bixler syndrome. HIV drugs like NRTIs, nucleoside or nucleotide reverse transcriptase inhibitors, lamivudine, zidovudine like zidovudine, abacavir, dedenosine, emtricitabine, stavudine, and non-nucleoside reverse transcriptase inhibitors like nevirapine, protease inhibitors like lopinavir, ritonavir, estion, etazanavir, indinavir, nelfinavir, ritonavir, saquinavir. First line drugs are tenofovir, emtricitabine, and efavirenz. Second line drugs are zidovudine, lamivudine, and efavirenz. Third line drugs are zidovudine, lamivudine, and nevirapine. First line drugs in HIV and their side effects: lamivudine over efavirenz, lamivudine over emtricitabine. It is better than emtricitabine because of the propylene glycol in the oral solution, and emtricitabine contraindicated in pregnancy. And tenofovir over zidovudine because zidovudine causes anemia. Bone demineralization effect of tenofovir has not been confirmed in human fetus. Efavirenz is category D drug. It causes birth defects in 2.8% offspring with first trimester exposure. Nevirapine is category B drug, an option for CD4 count less than 250. And coming to antivirals for hepatitis B virus, it is lamivudine, tenofovir, telbivudine are prescribed. And in case of hepatitis C virus, no drug has been approved for use during pregnancy. These ribavirin and interferon alpha are category X drugs. And in case of anti-helminthic drugs for nematodes, mebendazole category C drug, albendazole category C, ivermectin category C drug, and pyrantel palmoid category C, microfilaricidal, anti-microfilaricidal or diethyl carbamazepine and carbamazine, and for cestode and trematodes it is praziquantel, which is category B drug. Trypanosomiasis, actually it will cause intrauterine transmission can occur and abortion, stillbirths and premature labor. For the treatment as same as non-pregnant women in both like donovanosis, cutaneous donovanosis. Thank you, sir. Thank you everyone for giving me this opportunity.
Thank you, Lakshmi, for this elaborate talk on all the antibiotics and all the possible things that are available in obstetrical area. Tell us. Thank you very much. Madam, with your comments, Rekha Rajan, we will close it. Dr. Pramoda, would you like to add something?
Yeah, I don't have anything much to say. It was mixed bag. You covered many things and many topics usually we don't talk about, like though very practical. Under one platform, it is very difficult to get sometimes. Those kind of topics you have covered, especially the last topic, what she covered from all the angles.
Yes, madam.
Like textbook, if you go, it will be just chapter wise, like antibiotics in that, antibiotics in this situation, clinical situation, which is it's umbrella of everything she has covered under that umbrella.
Dr. Pramoda, would you like to add?
MC Patel sir is there.
Sir, Patel sir, are you here, sir? I think sir logged off, madam, or he is busy, sir.
No, in the participants, his
I
name
can
is
see,
there.
but sir,
Yeah, maybe. Just wanted to tell you.
Pramoda, madam. Pramoda, madam, would you like to add some comments?
Yes. Nothing, sir. Sir.
Yes, madam.
The session was very nice.
Thank you, madam.
Yes, sir. Hope to get more from your side, sir.
Dr. Geeta, madam. Dr. Geeta, madam, are you there? Okay. So thank you all for participating in this another excellent series of ABHYAS. Thank you all. Without you all, it wouldn't be a very good, successful. Monica, are you there? Monica?
Yes, sir.
Can you give the vote of thanks, please?
Yes, sir.
Good evening, everyone. Thank you for giving me this opportunity to propose the vote of thanks for this ABHYAS session. I thank our chief guest, Dr. M.C. Patel, sir, and guest of honor, Dr. Priyanka Roy, sir, Dr. Ganga Sutishmita, madam, Dr. Venkatesh Rao, sir, and all the presidents and secretaries of Guntur, Kadapa, Ongol, Mandri, and Vizag societies, Dr. Venkatesh Rao, sir, Dr. Umashankarsa, sir, Dr. Pramoda, madam, Dr. Pramoda, madam. I thank Dr. Aruna, madam, and Dr. Sridevi, madam, Dr. Padmaja, madam, Dr. Divya, madam, Vizag Society, Dr. Padmavati, madam, and Sailaja, madam, and our chairperson for the session, Dr. Geeta Vandana, madam, Dr. Pramoda, madam, and Dr. Sridevi, madam, and Dr. Divya, madam. Thank you for participating. I thank our speakers, Dr. Shama Sudha, madam, Dr. Rekha Rajendra Kumar, madam, Dr. Sirisha, madam, Dr. Lakshmi Priya, madam, and I thank our educational partner, Shield, for organizing this amazing session, and I thank our convener, Dr. Umashankarsa, for giving me this opportunity. Thank you.
Dr. Maunika, your Ganesha God and Shirdi Sai Baba should bless Dr. Umashankar and myself for the election. Thank you.
Shama. Thank you, Shama. Thank you, Pramoda. Bye, ma'am.
Thank you. So nice of you. Thank you so much for the nice session. Thank you. All the
best, sir and ma'am. All the best.
Thank you so much. We really need your blessings. Both of us know how difficult and how turmoil is going on in our mind. Yeah.
Pramoda, madam. Madam, is voting అయిపోయిందా, madam? Pramoda, madam.
Sir, late, sir.